Can you still hear me, Dr. McNamara?
I can hear you.
Oh,
And hopefully the participants that are coming in can hear you guys too. If you can hear us, can you just put a little chat in the box to say you can hear us or hi? I see a raised hand. Yes, okay. You can hear us. Great. We're going to give it about 30 more seconds just to let people file in, and we'll get this recorded as well. So just hang tight. All right, we'll go ahead and get things started. Just a couple housekeeping things. Thank you so much for being here tonight. I know it's end of summer and lots going on, so we appreciate the opportunity to present on a really important topic. Everything from about the California Bridge Program, our emergency department, to MOUD treatment and harm reduction. We are pleased to have Dr. Elizabeth McNamara here tonight with us, as well as Azzy I didn't get it right. Suave, I believe, Aslan Suave, and they're going to give the presentation. If you have questions throughout the talk, you are welcome to ask them in the Q&A box located at the bottom of your Zoom screen, or you can ask in the chat box, whichever is easiest. Feel free to ask them throughout the presentation. I'll help facilitate the Q&A at the end. And with that, I'm going to hand it over to our two speakers. Thanks so much for being here. And Dr. McNamara, oh, you saw the mute. There you go.
Thanks. I just had to switch offices real quick. All right. Hi, good evening. I'm Elizabeth McNamara. I am primarily an emergency physician, but I also act as a medical director of the CalBridge Behavioral Health Program and the sort of addiction medicine umbrella that we have at Barton, mostly on the emergency department side, but I also see patients in the clinic, and that's what I just finished doing today. And also here is Azzy, who's our substance use navigator at Barton. She's our care coordinator for patients who have substance use and has been really kind of the backbone of this program that I'm going to talk about today. So just briefly on goals and objectives. So first we'll touch briefly on language that we use when talking about these patients. Then I want to go into talking about fentanyl and the opioid epidemic, some national and local trends. OUD is an emergency and what our treatment program looks like here at Barton, benefits of treatment, and then briefly touch on bystander safety. This is an example of how we use person-first language. So we try to avoid language with our patients such as addict, junkie, druggie, alcoholic, tweaker, drug habit. And we use language like a person who uses drugs or a person with a diagnosis such as opioid use disorder, substance use disorder, alcohol use disorder, or a person in recovery. This tries to kind of avoid labeling patients and treat them a little bit more respectfully. And this is mostly what we're talking about these days. So fentanyl is a synthetic opioid that was developed in the 60s. It's very useful in medical settings. It can be delivered by multiple different routes. When it's formulated correctly for the delivery method of choice, it can be given intravenously, nasally through an atomizer, transdermally through patches that are specially designed for fentanyl absorption, and sometimes orally through lozenges. It's very effective for pain relief and sedation. It's much more potent than heroin and morphine. And in the emergency department, which as I said is sort of my primary job, we're using it on patients almost every day. It's also commonly used in anesthesia, in post-op, and in many other medical settings. Unfortunately, it's become essentially the backbone of the opioid epidemic for us. So this data, this figure is from a 2020 DEA intelligence report. And it kind of shows the flow of fentanyl into the United States as of 2019. So this is a couple years old, but majorly the emphasis here I just want to show is on the idea that fentanyl originates in a powder form in several places, a lot of times in China or India, and comes to the States, Canada, Mexico, throughout North America, and it's mixed, it's pressed into pills, it's processed with other drugs. And so it basically can be in anything. So we're seeing basically people who are taking what they think is an illicit opioid, a huge percentage, sometimes as much as 99% of them are getting fentanyl in there somewhere. Sometimes the media reports that it's like in marijuana or in other party drugs. Not seeing it quite as much, although any pills are kind of to be viewed suspect. But it's, anytime you're buying like a Xanax pill that you think is counterfeit, or maybe not you, anybody, anything that people are buying illicitly, it can be mixed in there. So that's really what we're worried about. And that's what you're seeing a lot of in the media with ideas of, somebody buys a pill, takes it, overdose, and it's fentanyl. This shows the effects of opioids by system. The systems we're obviously the most concerned about are the central nervous system, where you can see sedation and euphoria, and then the cardiorespiratory system, where you see respiratory depression, and bradycardia, which is a slow heart rate. So this is how fentanyl kills people, is it causes sedation, euphoria, they're unaware of their environment, and then it causes decreased respiratory drive, which is the primary driver behind fatality, and decreased heart rate as well. You can also see here, there's a constellation of other symptoms that are seen in people who have a history of opioid use disorder. They can have sort of side effects. They are also side effects of getting the medication even therapeutically, right? So people can have nausea and vomiting from getting an opioid. They can have constipation, urinary retention. It can cause depressed immunity, a number of other systemic complications. There's essentially been 3 waves in the rise of opioid overdose deaths. And you can see this is reporting starting in 1999 and going all the way to 2019. The first wave, which I think a lot of people are familiar with, was the rise in prescription opioids. And that was kind of driven by the pharmaceutical companies that now are paying settlement funds towards treating opioid use disorder. That was the first wave. The second wave started around 2010, which was an increase in heroin into the United States, mostly coming from Mexico. And you can see that's sort of the kind of darker blue line. And then what we're currently in, which is the third wave, is a huge rise in synthetic opioid overdose deaths, which started in 2013, continue to rise. And you can see this chart stops in 2019, and we know that overdose deaths significantly increased over the course of the pandemic. The data I don't have in this chart, but that I have sort of on the side here, shows that in the months from December 2021 to December of 2022, there was a significant increase in drug overdose deaths, to the point where 2021 reported 107,622 overdose deaths, which is huge. The biggest increase in deaths occurred in Washington and Wyoming, which was a 22% increase in each state. So you can kind of imagine where this chart goes after 2019. And in response to that, the CDC has made, what are appropriate opioid prescribing guidelines to try to de-emphasize opioid use for pain. But you can kind of see based on this chart that the ship has sailed at this point. Opioid prescriptions are going down over the years, starting in 2014, 2015, and really more closer to 2020. And you can just see overdose deaths shooting off, which is what is illustrated in the slide before. That's really when the synthetic opioids took off. And that's what we spend our days kind of working against. Here's some more local data. So from 2018 to 2021, just in El Dorado County, there's been a 371% increase in overdose deaths from 7 to 33. Over 80% of those deaths in 2021 involved fentanyl. And the unofficial number so far for 2022 was 43, which is, obviously even more. So this is a steep upward curve. This graph represents overdose rates throughout the state of California. And you can see the arrow in El Dorado County. It shows that we're kind of smack dab in the middle in terms of risk, in terms of the state. There's obviously some counties with much higher risk. Really close right there is Alpine County with a higher rate. But we kind of average out with other counties. You can see the kind of distribution skews more male, skews more a little bit younger, largely fentanyl, but there is a degree of other opioids. And then there's a fairly considerable racial distribution with minorities more represented oftentimes than others, but there's, not a huge difference. And all this is to say that opioid use disorder is an emergency. We know that about 5.5% of people who use opioids die within 1 year of a non-fatal overdose. And after a non-fatal overdose, 20% of people of that number die in the first month, and 22% of them die in the first 2 days. So by looking at this data, it really drives home how important it is that when we see patients in the emergency department who have opioid use disorder, who've had a non-fatal overdose, who have another complication related to their opioid use disorder, that we really attend to them quickly and try to help them with their opioid use disorder because they're at immediate risk of death.
Dr. McNamara,
Yep.
there's a little bit of a delay with your video, and I'm not sure if that's coming through for everyone or if it's just what we're seeing. Your audio is great.
Okay.
I'm not really sure what we can do to troubleshoot that unless I just want to make sure that it's not distracting for the participants.
Sorry about that.
That's okay. It actually looks like it's kind of self-correcting right now. The audio is still great. I just wanted to make sure that it wasn't distracting from the audience perspective. Is anyone any concerns? You can let us know in the chat. It looks like it's okay from our audience perspective. I'm sorry to interrupt. I just wanted to make sure before we kept going. Okay.
I want to make sure.
Go ahead.
So at Barton, we became involved with the California Bridge in 2019, and the California Bridge program helped to fund our treatment and help us expand treatment here for the last 2 years. And so the California Bridge model essentially has 3 components, which we've really undertaken here at Barton. The first is low barrier treatment. So we want to make it easier for people who have opioid use disorder to get Suboxone than to get fentanyl on the street. So we want them to come into the emergency department, make contact with a provider, and leave with the medications that can save their life immediately. The prior model for this, even as early as a few years ago when I worked in a different state, was that people had to get referred, they had to go through withdrawal, they ended up relapsing. And you can see from the prior slide that puts them at a huge immediate risk of death. So the first one is decreasing as many barriers to treatment as possible. The second is connection to care and community. So we want to not only easily connect patients with the care they need, but also provide any resources that we can to help them in the community. At Barton, we have a really nice setup because our outpatient clinics are across the street from the hospital and from the emergency department. So we can literally pick up the phone when we're in the emergency department, call over to the clinic and say, hey, I have this patient. I'm starting them on buprenorphine, starting them on Suboxone. Can you see them tomorrow? Can you see them next week? And that's been a really smooth transition for us. And then the third component is a culture of harm reduction. So harm reduction is essentially any practice that helps to decrease the chances of overdose or of contacting any illness in patients who are still using. So that's stuff like decreasing stigma, increasing trust and respect, making sure that patients know where they can go if they have a problem. One example that we use in the clinic all the time is that I tell my patients, hey, I'm not going to kick you out of clinic if you come in here having relapsed. I just want to see your face. So please come no matter what. And I've had, just in the past few months, I've had a number of patients who show up and they're like, I know, I haven't seen you in a while, but you told me to come and I'm here, I'm using, but I'm ready to start again. And that's a huge way to help with harm reduction. The substance use navigator has also been huge with that. So ASI has been absolutely fantastic in this role. The way that ASI helps these patients is that this is obviously a patient group that has high not only medical needs, but also social needs. Sometimes they don't have cell phones, they don't have stable housing, they may not have transportation. And so Azzy helps them to get from, I mean, essentially point A to point B, right? She meets them oftentimes in the emergency department. A lot of times, especially more recently, she's meeting them by text or phone call. They just get her number from somebody and they call her. She makes them a clinic appointment or meets them in the emergency department and talks to their provider about starting them on treatment. And then she facilitates it all the way through. So she sees them in clinic, she networks with them, she texts all my patients to remind them of their appointments. And if she didn't, I think I would have a lot more no-shows. And they text her when they run out of medications, they text her when their medications get stolen, they tell her that they need a ride. I mean, this is really intensive work to make sure that they feel connected and accepted, and also that they can make it to clinic. And in a classic model of clinic, you miss your 11 o'clock appointment, it's kind of done. But with the way that we can use the substance use navigator here, I had a patient today, missed his 11 o'clock appointment, came in at 3:30, super smooth transition. We knew he was coming, we knew what was going on, and we couldn't do that without a substance use navigator. Our emergency department has also been fantastic. When we first brought this as an idea of treatment, it was kind of another thing to learn, another thing to take on, another treatment model. And we've had wonderful adoption and destigmatization of opioid use disorders throughout the emergency department. And we're able to, not only identify the patients, but a lot of times it's nursing directed, not just Azzy, or they call Azzy, and the doctors have been absolutely fantastic about taking up the charge of like, okay, how much Suboxone do I give them? When can they be seen in clinic? And we know, based on the data collected by the California Bridge program and other programs, this actually is from a program out of Yale, that patients are more likely to stay engaged in addiction treatment, decrease opioid use, and decrease admission to the hospital if they have involvement of a substance use navigator, and if they have rapid initiation for buprenorphine. This is specifically referring to Suboxone initiation in the ER. And I'm sorry, I'm using Suboxone and buprenorphine sort of interchangeably, but for the purposes of this, it's the treatment and medication we use for treatment. But 78% versus 37%. So we've basically doubled the retention of patients in the program just by giving them the medications that they need to help them from the emergency department. So it's not just a decreased risk of death, but it's an increased risk of them engaging in treatment. I should say there's also data that these patients are less likely to leave against medical advice from the hospital because they are being appropriately treated for their addiction and they don't feel they have to leave. So I mentioned that at Barton, we have this sort of unique situation where we have our clinic across the street, and that really assists with not only the warm handoff, also just for patients navigating, and then just having a unified medical system where we can figure out who's taking care of patients, what medications they're on, what doses they're on. And that's been super helpful. We also participate with a number of other organizations locally that have been really supportive and helpful in developing kind of a coalition to attack this problem from multiple angles. So the police officers, the county, the jails, the California Department of Healthcare Services, Task, COPE, Excel, the Tahoe Coalition for the Homeless, and then, as I mentioned, the California Bridge program. And without Azzy, we wouldn't be able to really sustain all these partnerships because it takes a lot of meetings and networking and talking to people and figuring out who to talk to. So it's been really helpful to have the substance use navigator for this. All right, so as I was kind of mentioning before, patients come to our attention for this treatment program in essentially 4 ways. The first is they come directly through the emergency department, either in withdrawal or with a complaint related in some way to opioid use. So commonly patients come in with an abscess or cellulitis or dental pain or something like that. And you kind of ask them, hey, do you use any drugs? Do you need any help? And then that's the call we make to Azzy. Another way is patients just come directly to the Barton Community Health Center. They are already a known patient. They call for an appointment. They get in touch with Azzy. Third one, obviously, they just call Azzy directly as I was mentioning it, and that's happening more and more as she's sort of better known. We're getting a lot of referrals just from patients who say, oh, I have a friend, can you take care of them too? And the fourth one is that we're getting direct from providers referrals. So some providers are saying, hey, this patient, they had surgery a while ago, they've been on pain medications, it doesn't seem like it's going well, can you have a conversation with them? So we're doing a fair amount of that as well. And then here's what patients can expect when they come to clinic. The first thing is they can expect to get a prescription. The first time they come to clinic, we either start or continue a prescription for a patient to take buprenorphine, whether that's Suboxone or Subutex, depends on the patient, their experience, what their needs are. But they come out of the clinic with a prescription and instructions for starting their medications. They meet with the SUN, the Substance Use Navigator. We do screening for infectious diseases, so HIV, hepatitis C, hepatitis B, regular blood work if they need to. A lot of patients come to us for STD screening as well, so we'll do that. We also do harm reduction. We don't have a needle exchange program here, but we talk a lot with our patients about safe practices. So in addition to giving Narcan, which is the next icon there, we talk to patients about things like not using alone, making sure you have Narcan, making sure there's a friend nearby, calling 911, stuff like that. And then we're able to provide patients with as many as we can in terms of resources. A lot of times that's referral to the county for mental health services. And then we are able actually right now to offer free counseling to a certain subset of our patients that specifically focuses on substance use disorder. And I maybe should have mentioned this earlier, but Suboxone, I keep mentioning Suboxone, buprenorphine, but this is the medication. This is, the magical molecule, so to speak. This is what we use to treat patients for opioid use disorder. So Suboxone is a partial opioid agonist, which means it does block the pleasurable effects of opioids to reduce dependency, but it also helps to satisfy some of the craving for opioids so that people don't go into complete withdrawal. It will mute the pain blocking receptors in the brain activated by opioids, so it makes opioids less pleasurable, and at the same time, again, kind of helping to dampen severity of withdrawal symptoms. It will help to regulate brain chemistry. We see a lot of patients after they start on Suboxone, they just feel so much better, and that may be partly the Suboxone. It may be partly sort of getting out of the chase and not seeking and using drugs repeatedly over and over again, but people have so much more mental clarity and stability once they're on it. And, as we I've been mentioning it, it decreases and also will prevent overdoses. So people who are on Suboxone, it is part of harm reduction. If they choose to use, they are less likely to have a fatal overdose. And this is kind of an analogy I use for patients, instead of going down the highway at 60 miles an hour and running out of gas and going 0, and then going 60 miles an hour because they're high again and running out of gas and going to 0, the Suboxone keeps them at like a little bit more of a sustained, slower speed limit. So they're not in withdrawal, they're not intoxicated, they're safe, they're not going to get in trouble, but they're still moving along. Benefits of treatment, I kind of already touched on this. So patients are less likely to leave against medical advice from any medical treatment they need, not related to opioid use disorder. There's a decreased overall risk of death with patients in treatment. There's a lower risk of infectious diseases, including abscesses. There is a significant accountability factor associated with patients in treatment. I have patients in my own clinic who, some of them come every month, even when they're not using for years. And they come and we talk and they share what's happening in their lives. We talk about their medications and their doses. Most of the time, it's not for the purposes of tapering or stopping the medications. It's just to check in, and they're really taking a lot of ownership over their health, which is amazing. The life benefits follow with that. So obviously, safety is huge. There's a decreased risk of death. People are more engaged with their jobs and their families. We're seeing people go from being homeless to having somewhere to live, to getting their own place, to getting a job. They're more engaged with their families. And then they have increased financial security, which is really nice to see as well. So I stopped there for just a second to see if there's any questions, and then I wanted to touch briefly on bystander safety. But I think this is a good little break spot, and then we'll move on to the next few things. Anybody with questions for now? I don't see anything in the chat. Okay, so this slide is about bystander safety. There's obviously been a lot about this in the media, so I wanted to touch on this briefly. Oh, Darla, I see your question. I'll answer that in just a second. So exposure to powdered fentanyl or liquid fentanyl or fentanyl analogs and getting it on your skin or inhaling it or getting it on like your eyes or mucous membranes does not present a danger of overdose and death. There's plenty of videos out there that you can find that show police officers or other first responders with fentanyl that they're exposed to in some way who are acting as though they have an overdose. And the truth is that that would need to be intensive and prolonged exposure, like covering both of your palms with fentanyl patches for 15 minutes to get even a therapeutic dose, like 100 micrograms, which is what we give to somebody who has a broken wrist. The chances of somebody essentially dropping down from an exposure are, it's essentially impossible. And so this is dangerous information being disseminated in the media, and really it worsens the stigma of addressing these patients because I think it makes bystanders more afraid to go and help. The truth is that you can respond to a patient in an overdose and give Narcan without risk of exposure to yourself. You can do an assessment, look for, decreased respiratory rate. You can call 911, you can touch them and you're not at risk. Seconds count in the case of an overdose. And so it's really important to know and disseminate to other people that these people do not present a risk to you and that you can respond. Let me answer Darla's question before. I can't find it. Can somebody read that again for me? Oh, if you start overdosing, can you self-administer Narcan? No. Somebody's ability to recognize signs of overdose and administer Narcan it's counter to the way that it works. Most people are taking an opioid to become intoxicated and become euphoric, and they kind of gradually slip into a place where they would be in so much respiratory depression that they would be at risk of death. And so there's no sign that somebody would be like, oh, I'm too high, I need to self-administer Narcan. I've never had a patient who's done that. That's part of the reason why I have patients as part of harm reduction, is I encourage them to use with somebody else, because you need to be able to make an objective assessment of this person is not breathing to be able to reverse overdose. Natasha, I see there's another question, but I can't open it. I'm having an issue. Can you help?
I can read. It's from Joss G. Can you guys hear me?
Yeah, go ahead.
It's how can educators best support students dealing with this?
Do you mean students dealing with
probably opioid overdose, yeah, and opiate use?
That's a great question. So I think one thing is to make sure that you're also prepared, right? Have Narcan you can give to them. We can give Narcan to you to give to them. We've learned through decades of trying to scare people out of using drugs and alcohol that scaring them or encouraging abstinence is really not as effective as providing them with the information to get help for themselves. So the first thing being harm reduction, right? Like if they're not open to stopping, if they're not open to changing, making sure they have the tools at their disposal so that they don't die. So Narcan, use with a friend, smoke, don't inject, things like that. Use needles that are clean. And then the next step would be referring them to somewhere where they could have a non-judgmental conversation about options for treatment. So something like having them come to our clinic or letting them know that they can come to clinic when they're ready to talk about what their choices are. I find that there's a perception of, I come from the DARE era of, the police officers came and told us how bad drugs were. And I think that there's still some leftover perception that that doing that will help kids to stop. But I think that there are students who are curious. I think there are students who are exposed. I have a fair number of patients who started using when they were preteens. And so being really, really open to what they're going through, helping them to stay safe immediately, and finding them options for treatment, I think would be my recommendation for approach. Is there another question in the chat? Oh, Azzy, thank you. So Azzy put in a post there, a video to watch about how to identify overdose and as well as how to administer Narcan. Essentially what I can say is that your easiest way to identify overdose is watching somebody breathe. And if they're breathing at less than 10 breaths per minute, that is not sustainable and they need to be given Narcan and have 911 called immediately. If you do not have Narcan with you, you can, at your discretion, provide rescue breathing or call 911 immediately so that they can have first responders. All the police officers now also carry Narcan. And so typically people are able to get somebody there pretty quickly to help reverse overdose. Some people do require multiple doses. And so they almost all need to be transported to the hospital. Are there other questions? I'm going to go just through my last couple of slides here. So we touched on some of the person first language that we try to use for clinic, talked about fentanyl and the opioid epidemic, national and local trends and how we're kind of on par with the country in terms of, what's happening here, why and how OUD is an emergency and what our program here looks like at Barton, benefits of treatment, and touched a little bit on bystander safety and responding to an overdose. Azzy, perfect timing. So we are taking patients all the time. I have clinic twice a month. There's a number of other providers here who do opioid use disorder treatment. We also provide alcohol use disorder treatment. I overbook my clinic every day. Every time I'm here, I have like 20 people on my schedule and I'm happy to do that. I love it. Azzy is the easiest person to get in touch with. She can be texted, she can be called. The Barton Community Health Center can also be called directly to make an appointment with a provider for somebody to be seen. And for somebody who's in crisis, they're in withdrawal, they've overdosed, or they're just really ready to be done, we do provide, as I said, rapid access to medications from the emergency department and people can go there. We can have any other questions if you want. And then I wanted to let everybody know that August 31st is International Overdose Awareness Day. So we're going to be setting up some things at Barton to help to link with people who've experienced overdose or lost family members or loved ones to overdose, and also to give out Narcan and just provide more information on our treatment services.
Dr. McNamara, can you hear me?
Yep.
Oh, okay. Sorry, I think my mic went out for a minute. That was excellent. I know there were a couple other questions that came through, so I'll keep asking. Can you get addicted to Suboxone?
That's a great question. So addiction is identified not only by physical habituation, but also by people doing things to get access to a drug that they wouldn't otherwise do or that puts them in danger, right? So stealing, lying, putting themselves at risk of infectious diseases, compromising their jobs, compromising their families. So with that definition of addiction, people are not addicted to Suboxone. It's a prescription medication that they're taking every day. What I think you may be asking more directed is, are they hooked on it? Like, does their body require it? It does require tapering off of. So people come off fentanyl and they get on Suboxone. A lot of times they start on a slightly higher dose and then kind of taper down to a kind of maintenance dose, if you will. And then some people come off of it entirely. Some people stay on it for years and years and years. I have patients who, most of these patients are fairly young. As you saw, some kind of the skew of ages of people who are suffering with opioid addiction. But I have patients who've been on it for 10, 15 years. There are patients who are tapering down. My lowest patient is on 2 milligrams of Suboxone a day. We in clinic are treating it kind of like a blood pressure medication or an antidepressant. We go down to the lowest necessary dose that somebody needs for treatment, and they maintain on that dose as long as they want. There's no risk to staying on treatment long term. If people have an injury or an accident, they can still take an opioid full agonist. So they break a leg, they can still go to the emergency department, get oxycodone, get morphine, get whatever medication is necessary. If they need to have an appendectomy or other elective procedure, we do treat them the way that we would treat anybody, also with options to have the opioid sparing treatment. Then we come off the full agonist treatment, go back to their Suboxone dose.
Can you talk a little bit more about or talk about testing strips? Are they effective? How does that work?
Yeah, so yeah, that was really exciting when that first started. The idea being that there's a testing strip that kind of looks like a pregnancy test that you can put a small amount of your drug on and see if it has fentanyl in it. And it kind of works the reverse of a pregnancy test. So if there's a line, it's negative. If there's no line, it's positive. That was a great idea when we weren't sure if our drug supply was contaminated with fentanyl. At this point, I tell all of my patients, and everybody knows pretty much, that everything that somebody's taking has fentanyl in it. So I don't routinely recommend that people do test strips because I don't think it helps them differentiate between dangerous and not dangerous. There's also kind of a chocolate chip cookie analogy that a lot of people in addiction use to talk about it. Like, if you test part of your drug, are you testing the part that has fentanyl in it, or are you testing the part that has aspirin in it or Tylenol or something else? So, but when used correctly, if somebody wants to say, I really want to make sure I'm not taking fentanyl, it's definitely an option. At this point, like I said, I'm telling everybody, everything you're using has fentanyl in it. So making sure that you have somebody there to reverse an overdose is most important.
Great. And I think if maybe just one last time emphasizing the difference and maybe to the question earlier about how can educators help with students, the difference between overdose versus a poisoning, or I don't know if that language is interchangeable, but it seems like a lot of parents will hear overdose and just dismiss the topic because they don't see their child as someone who is taking pills or has an addiction issue. But I think the point you're making with fentanyl is that it's not really about, it can be one pill, one time, correct?
Yeah. So it can be one pill, one time. And we're certainly seeing that in the media right now. People never used before and they die from their first pill. And was it really their first pill, or did they hide it really well before? It's essentially irrelevant. I am very much on the side of giving information to age appropriate information to children and adolescents prepares them, and they're already hearing stuff about it. And so arming them with Narcan, it's like, I should have some with me, but they're only like this big. You can put it in a pocket, take it to a party, take it to a friend's house, be prepared to reverse overdose. Having children and students understand that Good Samaritan laws prevent them from getting in trouble if they call 911 for somebody who they suspect is having an overdose is also really important. Does that kind of answer your question, Natasha? Oh, you there?
Hi, Dr. McNamara. It's Azzy. I was just also putting in the chat some different links to some educational sites.
Yeah, I see. Thank you.
We also have Tahoe Alliance as far as educators and parents. We have Tahoe Alliance for Safe Kids, which has a kind of an app that you sign up for where you'll get notifications about what's trending within the elementary schools and high schools, and they kind of keep the public educated on what's going on as far as help available, harm reduction strategies, the types of drugs that are being seen, things like that. And I'm going to go ahead and post that also, the link to TASK, which is Tahoe Alliance for Safe Kids, in the chat. And I believe they do have some educational resources on their website too, in case you have any other things you want to research.
Thank you. That's really helpful. I appreciate it.
Are you guys able to hear me again?
Mm-hmm.
Okay, I'm so sorry. I haven't seen, I've been Azzy forwarding those links to the chat. So thank you for providing those. And I'll kind of start to wrap things up, but I'll be on the lookout for Q&A. Just wanted to remind folks, we'll get this recording up on our YouTube channel. It's been on Facebook. So you are welcome to come back and check that out at a later time because there's so much rich information in this. And then there's a survey at the conclusion of tonight's webinar. We'd love to get your feedback on how we did and any future topics that you would be interested in learning more about. So I am just keeping an eye. I don't see any last questions that have come in. But thank you so much, Dr. McNamara. Thank you, Azzy, for all the great information and for providing all these great resources. I think we'll go ahead and wrap it up unless you have any closing thoughts.
No, I can be reached at my Barton email for any questions or any sort of follow-up, and so can Azzy. Mine's just eMcNamara. I'll go back to the first slide for the spelling of my name, eMcNamara@bartonhealth.org. You can reach me if you have any questions, if you want to send a patient over. Please don't hesitate to get in touch. I know this was short. There's like a lot that you can touch on with this. This could be many presentations, but we want to be able to give a good overview of, oh, thank you. A good overview of what we can do here at Barton. And compared to hospitals of similar size to us in California, we're doing a fantastic job. Our program is, our services available are really widespread and well taken advantage of by our community. And we're seeing really good success with treatment. So please don't hesitate if you need any help.
Wonderful. Well, thank you again so much for an excellent, informative presentation. We really appreciate it. And I guess we'll give 15 minutes back to our attendees and to the rest of you. So thank you again, Dr. McNamara. Thank you, Azzy, for being here. Have a good rest of your night.
Thank you.